So welcome to the webinar Solutions for Immediate Full Arch Rehabilitation in One Day. I dare you to say that 3 times fast. The lecture is going to be presented by Wayne Zara, CDT, and we're going to begin shortly. And with that, it is my honor to be introducing Wayne Zara, CDT. He is the Technical Marketing Manager at ZimVie. Wayne is a graduate of Triton College and Southern Illinois University with degrees in dental technology and vocational education. With more than 35 years of dental experience, Wayne has presented numerous national and international seminars, including hands-on implants and implant prosthetic programs. As a published author, Wayne's technical articles have appeared in peer-reviewed journals, and he is recognized by the military as an outstanding seminar leader. Thank you, Wayne, for your time today, and it is my pleasure to say, take it away.
Oh, fantastic. So, Jessica, I hope that you can hear me just fine. I hope that you guys can all hear me. You just mentioned the military. I was actually at a military base for the Army yesterday in Texas, giving an all-day presentation. So I'm super happy to be home. Coming to you guys live here through our program. I see a thumbs up, so you guys hear me just fine. That's great. And coming to you from Chicago. So I live in a little suburb called Frankfort, which is about 45 minutes south of Chicago. And I'm super excited to be here tonight to talk to you for the next hour. And the topic of what we have is fantastic. The opportunities that are available for your patients and your practice is so good. And the topic is immediate full arch rehabilitation in one day. So we're talking about the process of placing implants, going through the process of placing abutments in temporary cylinders and little prosthetic screws. And we're attaching these components to a temporary prosthesis that will be inserted the day of the surgery. I mean, sometimes, don't get me wrong, there are times where we can take impressions and we can deliver the next day. So that's another type of process. But in most cases, these patients love to go home with their teeth, and they love to go home with that wonderful smile and be able to have function and have stability and to be able to just feel good again. And that's really what this program is all about. What I want to do for you tonight is give you my experiences, 21 years of experience working with full arch restorations. I do work for this company, ZimVie Dental, so I'm a ZimVie Dental employee. When I started with the company, it was called 3i Implant Innovations, and then it became Biomet 3i, then Zimmer Biomet, and here we are today. Our company name is called ZimVie. I'm in technical marketing support, and I travel throughout the world, and I help in presenting and mentoring these particular products. So I want to thank National Dentex and everybody within the organization, and also ZimVie for helping me orchestrate and put this together. And I'm really excited to be able to share the opportunity that we have. Before I go on to the next slide, I do want to share with you that I have a wonderful opportunity to share even more. And it's almost like stay tuned. So you want to be able to check your emails and things as time goes on when you get information from National Dentex Dental Labs. But what I want you to do, I want to tell you about some opportunities that we're going to have, which is in October and November. We actually have 5 dates set up where we're going to be at National Dentex Labs throughout the US, as an example, North America. And the plan is to be able to have an evening hands-on course. And we're going to have participation CE, and it's going to be absolutely awesome. So you're going to be able to actually convert a prosthesis, and then you're going to be able to have a model and a denture converted to a mini temporary that you're going to be able to take home and show your patients. So you're going to have a patient education model. So right now, currently, Davis, NDX Davis, Wyoming, Michigan is now scheduled on 10/17, so October 17th. And we also have Albenzi, which is in Irwin, Pennsylvania, and that is scheduled in October also, 10/24, so on the 24th. So again, check your emails and stay tuned. So I'm going to go ahead and begin. There is a little disclaimer. This material is intended for healthcare professionals. Distribution to any other recipient is prohibited. And then there's other information here. Just going to leave this up here for a couple more seconds and then go on. But disclaimer information always provided. So this is me. Again, Jessica, thank you very much for that wonderful introduction. But what's most important is that I'm a 32-year CDT, certified dental technician in complete dentures. I also have 35 years of experience working with implants and prosthetics, starting when working with manufacturers such as Sterngold, 3M, and here I am, Zimby, celebrating just over 21 years. So again, this night is all about bringing you experiences. But before I begin, I just want to share a couple of slides. So yes, I work for Zimby. Yes, I travel throughout the world. I present an average of about 100 of these seminars a year consistently for over 16 years. So it's like anywhere between 1,500 to 2,000 seminars. But so this is my family. My dad is in the upper left picture, which is a very cool picture. My dad's my mentor. He's a Navy trained dental technician, certified dental technician. He's retired. He's about 82, 83 years of age. And the picture of him sitting back in the lab smoking a cig. I mean, that's kind of how it was back in the day. And if you look at the picture on the bottom left, there is a hand-out articulator. There's a Bunsen burner. Yes, I said the word Bunsen burner. And a belt-driven handpiece, by the way. So you see all these things here. Pretty interesting. And then over the years, my dad not only was a teacher for 38 years at Triton College, teaching dental technology, hygiene, and assisting, but he also had his own laboratory. So I grew up my entire life around the laboratory business. And then this is me at a young age, teaching dental technology at SIU, Southern Illinois University at Carbondale. And I spent 3 years there teaching hygiene, assisting, and dental technology, and working in labs and so on. And just a great picture, a side-by-side of me and my mentor, my father. On the upper right-hand picture is my family. So I have my son, Jason, and his girlfriend, Allison. And then here's my daughter, Lauren, and her boyfriend, Zach. And then I have my wife, Colleen. So this is my family. And I also have at home here in Chicago, I actually have 4 horses. I have Tasty, I have Drift, Lady Liberty, Libby, and I also have Fred. So I have 4 horses, 2 crazy German Shepherds, and 5 cats. Yes, I said 5 cats. So when I'm out traveling and lecturing and teaching, this is what I get a chance to come home to. So I'm always happy to come home with everything that's going on. So I just thought it'd be interesting to share with you a little bit more information about myself. So this is my agenda. We're going to go through it very quickly. Get ready, have your pencil ready, have your camera ready to take pictures. And this is also being taped, so I'm sure there's going to be an opportunity to review this at a later time also. But a variety of different things to review, some definitions to know. What is full arch rehabilitation? Where do we begin? Setting the stage. What does the dental laboratory need to start the case? Very important. We got to go through that. What is a denture conversion? There's many different ways to convert a temporary prosthesis. Working with your laboratory, and the laboratory is the key to the success of the case. So the laboratory is always involved. We're going to talk about the big event, which is an actual case, and then we're going to end with some Q&A. And again, I know a lot. I've been involved in thousands of cases. I've been teaching this process for over 21 years, and I teach it today, and it's enjoyable. But there's so many changes that have occurred from 21 years ago, and success rates and so on, and materials to get it to the point of where we are today. So for you listening to this program, you are now involved in the best time ever in dentistry in regards to this full arch process. So we're going to go through it. So get ready. Okay. So my beginning slide is this. So according to the American College of Prosthodontists, more than 36 million Americans do not have any teeth. So there's opportunity. And 120 million people in the US are missing at least one tooth. These numbers are expected to grow in the next 2 decades. Now, for me personally, this is why I love this topic. And I love all topics of implant dentistry, but this one is special. And it's enthusiastic. It's emotional. It is a very emotional situation when you're talking to patients that have situations that, unfortunately, they're losing their teeth for whatever the reasons. But we change patients' lives. We give back patients' smiles. So this is what we do. I was lecturing in New York quite a while ago, and the surgeons that were sponsoring the program came up to me and they said, Wayne, you're really good at what you do, and I just want to show you something that we just did today to change a patient's life. And they sent me these pictures. And this is before, believe it or not, and then this is after. Now, this is a temporary. The picture on the right is a temporary. So the surgery was in the morning. The laboratory converted the temporary prosthesis, a temporary denture, that mid-morning afternoon. And the patient, basically, they came in at like 8 in the morning, and by 1 in the afternoon, they went home with that beautiful smile. And it truly is a game changer. So where do we begin? Well, when I talk about where do we begin, I also want you to know, as a company, ZimVie, working along with National Dentists and Laboratories, working with the laboratories over years. Now, keep in mind, there's over 48 National Dentists labs spread out throughout North America. I've been to most of them over my years, prosthetics and so on, and specializing in this process. So I've been to most of all these labs for the most part. But back in the day, 21 years of development and studies is what we've done to be able to sit here today and explain this process and know that it's not difficult. This is not rocket science. I will tell you, there's a lot that goes on to create the success of the case. But it's like, I want to go through this process to show you that the team effort is so important and that the process, the book is written, it's done. So by hearing what we're going to talk about tonight sets the stage for you and your practice to understand or get back to the basics and not leave out certain situations that are so important for the success of these cases with your patients. But as a company, as ZimVie, and working along with National Dentists, there's over 21 years of development and studies talking about this process. Now, a couple of definitions to know, okay? So I'm going to minimize my face here. I'm looking right here at my face. So I'm going to minimize that and go over a couple of really cool definitions for you. So immediate occlusal loading. What is that? It's a technique in which implants are restored and thus loaded at the time of their placement. What is a hybrid? So we're talking hybrid restorations. Think about this. When did a hybrid begin? Well, it began with Dr. Brannemark, all right? The founder of the word osseointegration. And he wasn't thinking about single tooth replacements. He was thinking about patients that were completely edentulous. We all have his books. I have his books. And in his books, when he talks about hybrids, hybrid dentistries, or high water, he talks about helping patients and he calls them denture cripples. Boy, what a harsh word. But that's what he talks about in his books back in the day. And he talks about the process of helping patients. No patient should die without their teeth. That was coined by Dr. Brannemark. So the idea of creating a hybrid. So what is a hybrid? A hybrid denture is a type of implanted denture designed to improve the support and strength of your dentures. Like removable dentures, hybrids sit on top of the teeth and gums. However, they are secured with little screws to the dental implant or prosthetics and cannot be removed without the help of an implant dentist or a dentist or denturist, whoever is working with the prosthetics. So they are fixed and they are only removable by you as doctors. But hybrids have been around a long time. Back in the day with Dr. Brannemark, they would place 5 implants, 5 abutments, 5 components, waxing and casting, and creating hybrid bars, and then processing acrylic and teeth, and then putting these little screws in. Truly amazing. So think about the history back then and how important it is today for you and for your practice and for your patients. So a little bit more detail. So what is an immediate occlusal load? A little bit more detail. Immediate occlusal loading is this. It's an implant placed with primary stability and a fully functional occlusion to an extent. IOL requires multiple implants rigidly splinted by a fixed prosthesis. Basically, if you broke your arm and you put a cast on your arm, it's not like you can't throw a baseball tomorrow, but you can throw a baseball when the cast comes off and your arm is healed and you go on with life. But that's what this is. This is like a cast on a broken arm. We're multiply splinting implants together, 4 or more, very traditional, 5 on the mandible and 6 on the maxilla, very predictable, but we do a lot of 4s. But the fact is we multiply splint, we cross-arch stabilize these prosthetics. And the patients go home the same day with their teeth in function, balanced occlusion, minimal distal cantilevers, about 5 to 7 millimeters off the last 2 implants. That's pretty normal. And at that point there, this restoration, as you see on the bottom right-hand side, is off the tissue by 1 to 2 millimeters. That's for cleansability and for healing. But this is a great concept or idea, which is a reality, which is called immediate occlusal loading. So words to know: lip line, cross-arch stabilization, you've already heard that. Cantilever, you've already heard the word cantilever. We're going to talk about vertical space, bone quality, bone reduction. People always say all the time, oh my gosh, they reduce so much bone. Well, there's a reason for that. Surgeons aren't just removing the bone, or implantologists just removing the bone for whatever the reason, but there are reasons. And we'll talk a little bit about that. Surgical torque, very important. We'll talk about that in a little bit too. And parafunctional concerns, such as bruxism or clinching, doesn't stop us at all in regards to full arch immediate occlusal load restorations. So we'll talk a little bit about that in more detail in just a little bit. So what is full arch? What is full arch rehabilitation? Well, full arch restoration is an innovative procedure that offers a brand new smile to patients who are in need of a full arch replacement. Full arch restoration involves the placement of 4, as an example, as a minimal, you got to have at least 4 dental implants in the patient's upper or lower jaw that are attached to a full denture. Many patients choose full arch restoration because this implant-supported denture offers them a brand new set of teeth in a single procedure, allowing them to begin enjoying the benefits of their new set of teeth right away. Now, I travel and I lecture all over the place, and I always pick up pearls, words, sayings from doctors and patients. So these are thoughts that I want to read off to you, and it's very important. Patients' thoughts, creating a new outlook on life, ability to chew again. I have my smile back, best investment. Being happy again, should have done this earlier. I hear that all the time. Every patient that I talk to says, yeah, it's a lot of money and there's a lot going on. But now that I've done this, boy, I wish I would have done this earlier. But these are some patient thoughts, and there's many more. Doctors' thoughts. We're eliminating disease. That's what we do. We eliminate the disease. We improve the quality of life of our patients. We're offering patient comfort. We're building relationships between the surgeon, the laboratory, the doctor, us as the manufacturer representatives, and your patient. It's also a very much known as a teamed approach, team-based approach. We don't do things as individuals anymore. We used to do things as individuals, and then things kind of didn't go as well as what we planned. But we do work together as a team. Personal gratification for all of us when we do these types of cases. It is very emotional, and it's wonderful for what we do for our patients. And the bottom line is what we do is we create confidence within our practice, and we create confidence within our patients and the ability to deliver these wonderful restorations. Now, as you know, your patients are becoming more and more aware of these opportunities every day. Internet, television commercials, newspaper advertisements, magazines, and radio. Patients are bombarded with information, and you know this. You're sitting up there late at night watching the TV and the news, and then all of a sudden an advertisement comes on, teeth in a day. Well, the bottom line is this. This is what's most important. Our patients are aware. More patients today are learning more about the opportunity that they have, especially when they see it or they hear about it. So the bottom line is this. When the patient comes to your practice and they come up and they see the gatekeeper, the front desk, one of the most important people in your practices, right? Besides you, of course. But that person is the first person that the patient sees. And when the patient walks in and says, hey, I saw this advertisement and it's called like this teeth in a day. Can you do this for me? I don't want that front desk person to say, well, hold on for a second. Let me go talk to the doctor and see. No, that's not what we do. What we do is we say, yes. We say, yes, we can do this. And what is the next question? What's the next question that the patient is going to ask? They want to know how much that it is. Now, I need you all to know the number. And you're going to have to talk with your surgeon. You're going to have to talk with your lab, and you need to know the number. The number could be anywhere between $22,000 to $32,000 to $36,000 for a single arch. $22,000 to $32,000 to $36,000 for a single arch. Boy, it's a lot of money, but it's worth every penny. But I need you to know the number. So you got to talk to your surgeon, talk to your lab, and you got to know the number. Now, the fact is that once you know that number, let's just say it's $27,000. It's in your head. Your front staff knows $27,000, but they don't say the number to the patient. Because if you mention the number, what's going to happen? They're going to be scared off. They're going to leave because it's a lot of money. But the bottom line is this. What we need to do, what this program is all about, is about identification. And that's what we need to do. We need to properly identify these particular patients, because once you identify and you have an opportunity, what you need to do is not tell the patient the cost. And that's up to you. I'm not telling you what to do. If you feel comfortable and confident to tell the cost and mention 28,000, whatever you want to do, and you know the numbers, then that's fine. But what I would almost rather have you do is say, let's see if you're a candidate, Mrs. Johnson. Let's see if you're a candidate for this process before we talk about cost or price. So what you would do is that you would get the patient over to the specialist and do a CBCT and then sit down and say, Mrs. Johnson, you're here for a reason. We're going to help you eliminate the disease, right? I don't know if we say that to your patient, but that's what we're doing. We're eliminating the disease. And for this reason of you being here today, and this information, this CBCT, this information and software, planning software tells me that you're a candidate for this process. Well, how much is this going to cost? It's going to be approximately right around $28,000. Oh my gosh, that's a lot of money. But keep in mind, you're a candidate. Let's talk about good, better, and best. So that's what this program is all about. When I talk about patient identification, who is a candidate? Well, you have edentulous patients and you have dentate patients, right? Edentulism is a state of complete loss of natural teeth, and dentate having one or more natural teeth. Why is it when I go in a lab, I look at a case pan and I see that the lab is making a prosthesis on one tooth? Oh my gosh, what are we doing here? But what happens when the patient loses that one last tooth? How do they feel? They feel old. And that's why they're hanging on to that one last tooth. But there are processes that we can do to truly help our patients. So we have two options. We have edentulous patients and we have dentate patients. Now, what's interesting is that the patient that accepts the treatment the most, and I hear this all over the world. I could be in Japan tomorrow and I hear the same thing. You know what I hear? We don't have the patients and it costs too much. Well, patients are finding ways to afford these prosthetics, number one. But number two, you have these patients out there. They are there. And the patient that I'm just going to tell you, this is the guy that you look for within your practice. If you say, I don't have these patients, this is the guy who accepts the treatment the most. And who is it? It's the dentate patient. Believe it or not, this is the patient that accepts a full arch rehabilitation treatment the most. And why? Because number one, they have a high caries rate. Number two, they're worn out with traditional dentistry, piecemealing the case. And number three, they don't want to go without their teeth. So they have a denture and the opposing in this case. And then they have a partial denture supported by 1, 2, 3, 4, 5 failing dentition, partial denture. So let's look at that particular case. So what we have, this is a before and an after. So in this before picture, that patient here, we made a denture on the opposing, a new denture. And then on the lower, they have some periodontal involvement. They have some teeth that have some issues. And unfortunately, they're going to leave us. So what did we do? We went through a process of placing implants. The picture in the upper right, that's actually from ZimVie. That is actually my T3 Pro. That's my certain connection and low profile abutments. And then on the bottom, that's my new and improved TSV. It's like a TSV on steroids called TSX. It's absolutely awesome. But the TSX has the new multi-unit abutments and then temp cylinders and screws. So what did we do in this case? Well, we place implants. We place the abutments that come in either straight with different tissue cup heights. We also have different angles of 17 and 30. So we have angle componentry, and there's reasons why we use that. We'll talk about that in a little bit. But once all these components are on, we don't work deep into the tissues anymore. What we do is we work what we call high and dry. So these abutments typically are supported and supplied by the surgeon. And sometimes the labs do too. But most surgeons have a stock of all these components. So they have all the different heights and the different angles. So the idea with the heights is to be able to get them right at the crest of the tissue or slightly above, depending on upper and lower in the situations. But usually they're at the crest or slightly above. And then we also have angled components. And again, we'll talk about the reasons for those in just a bit. But you can see the pictures on the bottom left. You can see where the access holes are. Everything's tucked in lingual. That is so important. Back in the day, we didn't have all these angle components. So what would happen is that wherever the implants went in, wherever the bone was, is where the implants went in. And then the access holes were coming out the face of a tooth. They were coming out the buccal of a tooth. They were coming out in the incisal edge. They were all over the place. But now what we do is we place our components and we get the access holes where that they need to be. So it's easy for you. It's better prosthetically for our technicians, making beautiful restorations at NDX. And it gives you the ability to have wonderful opportunities to be able to retrieve these restorations. So in this case, we placed 4 implants, 4 abutments, 4 temp cylinders, and 4 screws. And we have a temporary prosthesis, which was luted together with resins and composites and so on. We minimized our distal cantilever 4 to 5 millimeters, maybe the length of about a premolar as an example. And we also polished and finished. We went ahead and polished all the the ridge support. It's off the tissue by 1 to 2 millimeters as an example. The flange is also reduced. It's polished and finished. I'm going to show you guys some examples of what these things look like when we talk about the conversion process. But that's a great example of a temporary prosthesis, which is placed at the time of the surgery. It's all about balanced occlusion, soft diet. Soft diet is the key. my good friend, Harold Baumgartner, Dr. Harold Baumgartner, Perio Press over at Penn, speaker all over the world talking about implants and prosthetics, said, and I'll never forget this. I was at a meeting downtown Chicago, big meeting, thousands of people in the audience, and he says, anything that you hear in your head is too much. So I'm talking about the biting forces, and I'm talking about chewing, and I'm talking about foods. Anything that you hear in your head is too much. What do I mean? Croutons. I'm talking about chips, pretzels, ice cubes. It needs to be soft diet. And for how long? For however long that the temporary is going to be in, 2 months, 4 months, 6 months, 8 months, maybe a year. And that's up to the surgeon and that protocol. But soft diet is very, very important. We're talking soups, eggs, potatoes, whatever it is, the diet, that is available for our patients. But the bottom line is they come in looking like this before, and they go home looking like this after, and they have a wonderful, wonderful smile. Now, I will tell you this process, like I said, is very emotional, and there's a personal gratification for all of us when we do these types of cases. This is like my favorite picture for the last 16, 17, 21 years. I've been on the road teaching this process for 16 years. Been with the company for 21 years. And, but that's like one of my most favorite pictures. The handshake, of the patient saying goodbye and saying thank you. The handshake is awesome. You talk about gratification, doesn't get any better than that for you in your practice. So where do we begin, right? We talk about good, better, and best. Good is a denture, better is an overdenture removable, but the best is fixed. Good, better, best. So very quickly, removable denture is good. Least costly approach, fast to fabricate, contributes to further bone loss, ongoing expenses to maintain relines, adhesives, and cleaners, loose fitting, difficult to eat and speak, lower nutritional state, self-confidence, and overall quality of life. Isn't that great with a removable prosthesis? Now, I don't know if you guys know this or not, but did you know, according to the World Health Organization, did you know that edentulism is actually listed as a disability and a handicap? Did you know that? It's a disability because it limits a patient's ability to perform two essential tasks in life, which is speaking and eating. It's also listed as a handicap because significant changes are needed in order to compensate for these deficiencies. When I talk about removable dentures, dentures accelerate bone loss. This is what makes dentures loose. Patients are not aware of this. The biggest difference between natural teeth and dentures is biting force. With your natural teeth, we're somewhere between 2 and 250 pounds of force. Some a little less, some a little bit more, but that's the sweet spot. With dentures, your biting force is right around 50 pounds. Man, we got to help these people. And people ask me all the time, Wayne, who's your competition in the industry? You know who my competition is? It's when you go to the grocery store. You go to CVS, you go to Walgreens, and you look on the shelf and you see all the adhesives. That's my competition, the goos and the gels. And we can eliminate the goos and the gels for the patient for the rest of their life. But we got to help these people with only 50 pounds of force. It's kind of funny. Down below the line is 650, and a great white shark is 4,000 pounds of force. Good, better, best. Let's talk about better. Better is a removable overdenture, right? It is removable. We still take it out and put it in a little glass of water at night, but it is better. What do implants do? They preserve the bone. What do the overdenture attachments do? They give you function, stability, retention, support, aesthetics, ease of maintenance. So I am a big fan of overdentures. Next, least costly approach, fast to fabricate, better fixation of teeth, improved chewing ability. There are other considerations, ongoing expenses to maintain. We're talking relines and cleaners. Back in the 1980s, when I was at Sterngold, we were talking about ball attachments and all the different ways to restore a ball attachment. We also talked about the Hater bar, still the number one overdenture removable clip bar system in the world, the Hater bar. Back in 1990, when I started at Sterngold, just a little prior to that, we launched the ERA attachment, which knocked out the ball attachment, but the ERA was absolutely awesome, and it's still available today from Sterngold. And then in 2002, our company, Zimvi, helped launch the locator to the world, talking about implants and prosthetics. That was in 2002, the locator. And today we have what's called the overdenture. And the overdenture is the new and improved locator. So check it out. Very cool. Called the overdenture. So the two implant supported overdenture is a very, very viable option. And I always want you to keep that in your back pocket. So I want you to meet Al, 82 years of age, and I can't eat with my lower denture. This is my daughter, Lauren, that's Al, and her horse, Fred. She rides barrels. She's a barrel rider. And so with Al, I said, we need to help you. So we went to the specialist and we noticed that he has a lot of bone on the mandible and he's got a good smile. You guys think he's got a good smile, but he's only supported by 4 teeth. Now, what did we do? We went through the process. I talked to my good friend, Dr. Bill Haji Harris, Dr. Haji Harris at Midland Oral Surgery and Implant Center in Frankfort, Illinois, my little town. And what we did was we placed 2 implants, 2 TSV implants. And then the next 3 months, we healed and we got the thumbs up of osseointegration. We placed some healing abutments. At that point there, Dr. Bob Davis, Lincoln Way Family Dental in Mokina, Illinois, helped us with this case. And we matured the tissue for a couple of weeks. We measured the tissue. We chose the overdenture abutments. We hollowed out the prosthesis. We did do a reline on his existing denture that he never wore, by the way, because he didn't like his denture and he didn't like it moving around, and it was always a problem. But we did do a lab reline in the morning, and then we hollowed it out, and we picked up these metal housings, and we changed out the attachments. And I gave him one of the lightest, which is blue, and it snapped in great. And eventually we did change him to pink, which worked out beautiful. But he went home and he ate his steak. And I got to tell you, that was the best smile, that right-hand picture. That was the best smile I got of Al. And I've known the guy for like 17 years. And it was absolutely awesome. So always keep in mind, a 2 implant supported overdenture is a very, very viable option. Now, this is a beautiful slide. Take a picture of this one. This is a great slide. This is from one of my good friends, prosthodontist Dr. Paulino Castellan. And I watched one of his seminars and I said, I need this slide. And it talks about chewing efficiency. So, for example, on the mandible, chewing efficiency. If you have a lower denture, your chewing efficiency is rated at 10%. If you have an implant-borne supported tissue-borne prosthesis, which is an overdenture, removable, you're talking 60%. If you have an implant-borne bridge, which is the title of tonight, that's the topic of tonight, we're talking 90%. That's a hybrid. If you have all your teeth, we're all hundies. If you have no teeth, no denture, you know what the doctor says to the patient? They say, Mrs. Jones, you are a 0. Maybe they won't say that. Probably not. But the fact is, it's really important to understand 10, 60, and 90. Where do you want to be as a patient? Good, better, and best. So lastly, when I talk about overdentures, they're classified in 3 different classifications. You have implant retained mucosally supported, which is an overdenture removable. That would be like the overdenture or locator type case. Bar retained implant supported. If the ridge is very flat, very, very flat, 4 implants, hater bar, clip overdenture removable, wonderful. Or what we'd be thinking, if you get 4 implants in, I'm not thinking about removable anymore. I'm thinking about fixed, a fixed prosthesis. And that's the title of tonight. So let's talk about fixed. Some of the benefits: best fit, most like natural teeth, no dietary limitations, food tastes normal, preserves bone and facial structures, permanent solution. Patients want to have what they had before they lost their teeth. Do you all agree? Absolutely. Who wants to take their teeth out and put them in a glass of water? And you're young or middle-aged or you're older. Who wants to do that? The youngest patient I've ever been involved in, Eddie, ectodermal dysplasia. He was like 18, 19. He was a senior in high school. And I remember being at the surgery and in front of his parents. And what gives me the right to ask this question to Eddie, who's just a young man? And I said, Eddie, do you know why you're doing this? And I get emotional when I talk about this. I said, Eddie, do you know why you're doing this? The plan was to place 5 implants on the mandible. He's 18, 19 years of age. He's done growing. All of that was determined. And Eddie said this. He goes, you know, Wayne, you know why I'm doing this? Because someday when I get married, I don't want my wife to think that I don't have any teeth and my teeth come out and go in a glass of water at night. We were all so emotional. But we went through the process. We placed our 5 implants. We placed our abutments, our cylinders, and our screws. He woke up out of his twilight. He's moving his tongue around. He's like, oh my gosh, my teeth, they don't move. It was amazing. And eventually over time, I'm sure probably more implants might have gone in, probably made more crown and bridge type restorations. And, but it was awesome. But for me, the youngest patient was like 18, 19 years of age. The oldest patient, 93. Marcia, who was at the office, sent me a text and says, hey, this is going to be a great case. Do you think you can come by and check it out? And I said, well, what's going on? And she says, well, patient's 93. We're going to do it in the OR. And what we're going to do is we're going to come back and we're going to do the conversion. And I said, oh my gosh, that patient's got to be one of the oldest, I think. And you know what Marcia said? Yes, he is one of the oldest, but he doesn't want to die without his teeth. Oh my gosh, just so emotional, right? So we talked about hybrids. We talked about the features and the benefits. What is a hybrid? It allows for aesthetics, function, and lip support. On the left-hand side, that's pretty traditional. that's pretty traditional. That's actually a Bellatech bar, CAD-CAM mill bar with acrylic and denture teeth. That's still probably 75–80% of our business. The next picture is actually a copy mill. That's a resin pattern, which is copied and milled for either ceramics or for composite. This is applying Gradia, and it's a laboratory composite. So these are other options for hybrids. And of course, zirconia, right? So it's a puck, and it's milled, and it's sintered, and for shrunk at percentages and time and heat. And the teeth look beautiful. They have beautiful function and stability. You see how the implants are all tucked in a little bit lingual, which is awesome. And according to our AP spread, we were able to get a second molar, second premolar, second molar occlusion in these particular cases. So very, very cool, different examples of hybrid restorations. Now, keep in mind that every decision was made with these patients to keep their existing teeth, but unfortunately, they could not be saved. These are beautiful pictures of befores and afters. Now, the afters are their final restorations, but keep in mind the temporary mocks the final restoration. That's what I love about immediate loading, because we're test driving the case. We're making sure that the patient can take care of it, make sure they can keep it clean. And then from here, we change the aesthetics or the position of the teeth or the color or the shape. Anything we do is within the temporary before the final. That's what I love. It's like I'm an F-150 guy. I love my trucks. And wouldn't it be cool to be able to test drive an F-150 for like 4 months and then pick out all the things that you don't like, but all the things that you want to change and how you want to make it better. And then basically from here, you can go ahead and order up your new truck with all the things that you enjoy. That's what this process does. So let's talk about setting the stage. Number one, when you guys get a chance, I want you to take a picture, take a look at this, look it up. It's called RealGuide. RealGuide is a software from our company, Zimvi, and it's absolutely awesome for treatment planning. It's a beautiful treatment planning process software. The reason why I mention it is because NDX is also involved within the software of RealGuide. But we always begin with a CBCT, and we also do a virtual surgery planning with some type of software to be able to design these types of cases. When we talk about bone quality, we talk about quality, volume, and bone width. So we're talking type 1, type 2, type 3, not in type 4. But now we have implants nowadays where we can place it in type 4, and we can achieve at least, check this out, 35 Newton centimeters of surgical insertion torque to be able to do these types of cases. You need at least 35 Newton centimeters of surgical insertion torque to do these types of cases. Now, the bone height, you need at least 12 millimeters to allow for at least a 10 millimeter implant. And then you also need to at least have a 4 millimeter bone width of 6 millimeters for at least for a 4 millimeters. So the minimal, typically what we think about is a 4 as an example. Sometimes we can have implants nowadays where we can get them to be a little bit smaller in diameter. We actually have what's called a 2.9 or a 3.1 connection that gives us the ability to do full arch cases. But 4 is kind of the standard in width, and 10 is kind of the standard in length. Vertical space. Vertical space is so important to understand when you do these hybrids. You need at least 15 to 18 millimeters of overall vertical space. Now, what does that include? That includes the abutment, the bar, the space, the acrylic, and the teeth. You got to have at least 15 millimeters. And where does that millimeters come from? From the implant platform to the incisal edge of the restoration. So when you do these hybrids, guys, you need at least 15, 18 millimeters. What happens if you don't have 15, 18 millimeters, or we don't reduce enough bone for the proper placement of these implants? Well, what we have found out over the years is the potential problems of screw loosening in your temporary, or fracturing of teeth or acrylic resins. So we need, and the lab knows that we need at least 15 to 18 millimeters of overall vertical space. Now, we also talk about AP spread. AP spread, anterior posterior spread. We're not just placing implants and then guesstimating where all the prosthetics go. We actually do this systematically, and we go back to the days of Charlie English, prosthodontist, Dr. Charlie English, back in the 1990s, and we talk about AP spread. So for example, when we treatment plan our implants, 1, 2, 3, 4, we got 5 implants. What we do is we make a horizontal line to the 2 most posterior implants. We make a horizontal line across the most anterior implants. We measure in between what? By how much? 1.5. And that tells me how far back I can cantilever my prosthesis. If these implants are too close together, and my assumption here in regards to AP spread is shorter, well, we might not be able to give that patient a first molar occlusion, and that's what they want. In this case here, we only went back to a second premolar, but for this particular case, the patient was very satisfied with that. But we do utilize AP spread in determining or calculating the cantilever, not in the temporary, but in the final restoration. Now, smile line, very important. A lot of photographs, full face, lip at rest, full smile, left lateral rest and full smile, right lateral at rest and full smile. Photographs. You need as many photographs as you can to take of your patient for the laboratory to make the prosthesis. Sometimes we talk about transitional line. This is more important on the maxillary case. The bottom line is the junction between the natural pink and artificial pink is affected by lip mobility, smile line, amount of bone, and size of teeth. It is very important that when a patient smiles, that the flange of the temporary prosthesis is not visible. Now, if it is visible, that's a problem. So maybe this patient is not a candidate for a hybrid, maybe a fixed detachable. So maybe they go home with a denture and that doesn't go home fixed, but maybe we'll do a fixed detachable or maybe a removable later on. But this is why the photographs are so important. So when you see a patient smile and they show a lot of tissue, a lot of gums, maybe they're not a candidate for this process, depending on the treatment plan and the situation. So we've gotten the patient to say yes. Now, what does the laboratory need to start your case? The bottom line is this. I mentioned this earlier, a lot of photographs. You're going to take good impressions to make models. The laboratory is going to pour in the model. They're going to articulate your case. So this is how we begin. We take good impressions and we take lots of photographs. What the laboratory does is they create for you an immediate prosthesis. And what we're going to do is the lab's going to measure 15 millimeters from the incisal edge down. They're going to remove the teeth. They're going to make you've all made immediate dentures. And that's basically what we're doing here. The laboratory has this articulated. They're going to do a setup and they're going to make a temporary prosthesis. And this is an example of my son on the right and the left. Same, that's my son. That's Jason working in the lab making dentures. But that's what the lab is going to do. And they're going to make you a denture. They might print it for you. They might mill it for you or make it traditional. In this example, the dental laboratory fabricated not only the denture, but they also duplicate the denture and they make it as a clear surgical stent. Many people still fabricate these cases and deliver these restorations the same day, utilizing a traditional process, which is a denture converted and also utilizing a surgical stent. And that stent is hollowed out because it helps us in placement of our implants. It helps us in angle correction and also helps us to understand bone reduction. So you got all these variables, but this is very traditional. This is probably 75, 80% of our business. The other percent is going through the process of digital dentistry, which is a whole nother program. It's a whole nother process. So we're going to talk about that when we go live and we do our hands-on courses. But there's a whole other process in regards to that, or even guided surgery with stackable componentry, which is pre-made by the lab or pre-made by another manufacturer. So what is a denture conversion? Very quickly, during the dental implant placement, a complete removable denture is converted into a temporary fixed prosthesis. This prosthesis is worn by the patient from the day of the surgery until the delivery of the final permanent restoration. Denture conversion. Now, there's many different ways to convert a prosthesis. Traditionally, chairside pickup. So we have a denture and we go through a process of creating holes and we cure in with acrylics and composites, these old temp cylinders. We polish and we finish and we deliver these wonderful temporary restorations. This is very traditional. Now, this process over here, pretty cool. Smart denture conversions. Look that up, check it out with ZimV, and it's another chairside pickup. But what it does is that it makes smaller holes. They say we cut back time considerably, where a traditional chairside conversion can take anywhere between an hour to 2 hours. They say that the smart denture conversion not only makes the hole smaller, but increases the strength of the temporary prosthesis. But they say that you can do it within 30 minutes from start to finish, delivering a temporary restoration. Check it out, called smart denture conversions. Sometimes we do fully guided. We do a CBCT, we do software, we do intraoral scanning, we utilize software such as RealGuide as an example, and then we create stackable guides and stackable prosthetics, and we deliver restorations fully guided, which is absolutely awesome. And I wish it was just the opposite of traditional freehand dentistry, but it's not. But it's growing every day, and the cost has come down considerably. So fully guided is definitely an option. And lastly, photogrammetry is another option too. That's more newer to our business in the last maybe 5 or 6 years. And not only does it help us to create these temporaries, but it also helps accelerate through digital processes the final restoration. Now, check this out. How old is this temporary? I'm doing okay on time. We're almost done. How old is this temporary? How old is that temporary? What do you guys think? Is it a year? Is it a 2-year-old temporary? Look at it. It's terrible. 2-week-old temporary, lack of vertical space, contacting tissue, sharp edges, voids not filled in, inaccurate resonance, fracture on the midline, and teeth fracture. Oh my gosh, there's so much. This is terrible. This is what gives this process a bad name. What we do and what you will learn from working with National Dentex, all the laboratories, all 48 of the labs throughout North America, they all do this. And the ability to create for you beautiful temporaries with minimal distal cantilevers, polished, finished, maybe a little festooning, so that when the patient's feeling it, that it doesn't feel like there's just a flat line. It feels more natural with festooning. And then we also fill in all the voids. We polish, we finish to a high luster, and that's what the patient goes home with as their temporary. This is what we teach. The other thing to notice in this picture, notice how they're all tucked in lingual. So nice, so pretty, beautiful temporary restorations. And this is all done freehand, or it could be done guided. So let's bring this all in. Let's bring you home. Let's talk about the big event. So for example, an immediate load, same day opportunity. Look at this patient. Look at this opportunity. On the maxillary arch, they have 4 implants supported by 4 locator attachments. They did a treatment plan. They did software to determine vertical and positioning and heights. At that point there, we also have a surgical stent. So the teeth were extracted, the disease is being eliminated. We're going to minimize the bone and flatten the surface to get our 6 millimeters in width, as an example, to get our 4 millimeter implant in. And we're going to utilize this clear stent, right, as the prosthesis to help us not only in placing our implants, but placing our abutments, angle correction if necessary, right? It does all of these wonderful things for us. And that's a great example of a surgical stent, reducing bone and placing the implants and placing the abutments. Now, these are the abutments that would be placed, and we place angulated attachments, angulated abutments, and there's reasons why we place angulated abutments, and there's 3 reasons. Number one, we're avoiding anatomical structures. Who wants to do a sinus lift and spend more money and wait more time for healing? You don't have to do that because we place the implants forward to the sinus, and then we angulate to get our proper access with our angled attachments. We also increase AP spread by angulating the posterior implants, increase AP spread to give the patient what they want in regards to posterior occlusion, which is first molar occlusion in the final restoration. And lastly, what would be number 3? What do you guys think? Avoiding anatomical structures, increasing AP spread. Believe it or not, placing a longer implant gives us the ability to have more bone implant contact, more primary stability, gives us higher surgical insertion torques of 35 or higher, as an example. So in this case here, the abutments are in, the abutments are x-rayed, the abutments are torqued. This is a traditional process. We take the denture that we're going to utilize as the conversion, and we put some impression material inside that denture, a bite registration. We seat it in the mouth, and we take it out, and then you see the indentations in the impression material. Do you guys all see that? You guys see that? What we're going to do is we're going to take some burrs, and we're going to hollow out the prosthesis. We're going to place our temporary cylinders on. We're going to seat the prosthesis. We're going to check the bite. Popsicle stick, right? Very expensive popsicle stick. And we still do these. We put a popsicle stick and we make a dot on the nose and a dot on the chin. We make the 2 dots on our popsicle stick and we measure that. And that's how we help choose our vertical. And we use that popsicle stick like 10, 12 times throughout this process. But what we're going to do is we place the cylinders and we put the denture on. And then we check the bite. And if we have to reduce the cylinders, we reduce the cylinders. We mark them, we take them outside the mouth, Joe Dandy disc, fireworks, and we go through this process of cutting our cylinders down. We put the cylinders back in the mouth, we check our bite, we put rubber dam, always put down rubber dam to protect the tissue. And then at that point there, we seat the prosthesis. We do put a little Teflon tape inside the screw access holes, and then we're going to syringe in some composites or acrylics. You're going to do this in the hands-on, by the way, if you're involved in our hands-on courses. Check that out. You'll see those emails coming later soon. But we're going to add in the resin. We're going to let it set. We're going to take it out. We're going to polish. We're going to finish. And then we're going to deliver this beautiful temporary restoration. And the patient's going to go home. You're going to put the little screws in. You're going to torque. You're going to x-ray and torque. And then you're probably going to put a little bit of impression material inside those access holes and just send the patient home, balance the occlusion, talk about the soft diet. And, and that's how we do it. That's 1 week post-op. And then 4 months later, in this case, we took impressions, or we do digital dentistry with scan bodies. There's all different ways to deliver final restorations, but that's a great example of a final hybrid restoration. That's a CAD/CAM mill bar with acrylic and denture teeth. We're checking the bite. Just a very cool, beautiful restoration. And that's 4 months later. So a couple last slides and I'm done. Post-operative instructions: soft diet for the first 3 months for healing purposes when they have temporary prosthesis. Strong hygiene, as the temporary prosthesis sits differently onto the gums. I'm going to tell you right now, after about 2 weeks, they can start using their water pick, but the water pick, the floss, all of these things are the patient's best friends to be able to keep this clean. During the first 2 weeks, use a monojet syringe to gently clean underneath the prosthesis. But like I said, the water pick is going to be the patient's best friend. So in summary, why does full arch rehabilitation work? And I'm excited about this. I love these cases. I love being involved. I love talking about them. And I love seeing the patient and the final results. But why does it work? Well, number one, we as a company working along with National Dentex, ZimVie and National Dentex together, we have over 21 years of history of clinical success. Surgical insertion torque, you need at least 35 Newton centimeters or higher. And if you don't get that, we have to make sure that the patient understands that if we don't get the surgical insertion torque that we need, then the patient's going to go home with their implants, but they're going to go home with a prosthesis, but it's going to be removable. So you got to let the patient know about that. If they don't get the proper bone densities or qualities that we expect, that they may not go home fixed. But the odds of going home fixed is probably like 98%, believe it or not. Now, sometimes if we don't have good insertion torque, maybe we can go a little bit wider. Maybe we can bury the implant and still connect 4 together, and we'll jumpstart the implant later on. Let it heal, right? Multiple splinting and cross-arch stabilization. That's the key. Like a broken arm on a cast, right? Cast. Minimal distal cantilever, 5 to 7 millimeters. Balanced occlusion, soft diet. How long? For the life of the temporary. It's a temp, but I don't want it to break. Exceptional patient follow-up and maintenance. People ask me all the time, they're like, well, we have the patient keeping it clean. They're doing a great job. I'm going to tell you, if they don't keep it clean in the temporary, that's what I love about temporaries. If they don't keep it clean, then they are not a candidate for this process. And the implants will fail. That's what my surgeons say. The implants will fail if they don't keep it clean. So the fact is we have good follow-up with our patients' maintenance and good care of follow-up with the final restoration. People ask me all the time, hey, how often do you take off the final prosthesis? Well, bottom line is this. My prosthodontic friends say this. My good friend, Dr. Gary Morris, my good friend, Dr. Paulino Castellan. What do they say? They say you only take it off if you need to, right? Unless there's a reason to. And the little prosthetic screws, change those accordingly. Change them accordingly. And the bottom line, why does this work? Well, it works because of teamwork. It works because we have a team between your surgeon, your doctor, your implant placer, your specialist, your denturist, the dental technician, everybody at National Dentex, us as a company at ZimVie, the componentry, the implants, and of course the patient. This is what makes these cases so successful. So I was asked to put a couple of resources in here. So a variety of different slides have different information where you can find more information, such as the AP spread and some other things here. The World Health Organization in regards to the word edentulism and so on. If you're looking for more things, it is right here as a resource.